Hi. Hi, everybody, dear colleagues and dear friends. Today, I'm honored to introduce a distinguished scientist and speaker. He is the president of Interasma, and he is also the chair of the Research Institute for Heart and Lung Diseases, and he is a research center. And he is also professor of medicine at Laval University in Quebec City in Canada. He is a great scientist, and I have to say that I know him since quite a few years, and I was always really keen to learn from him, also because of his really great and qualified scientific production. All this made him a leader in asthma. And as a leader now, he is also chair, and I'm pleased to say, is chair of the GINA document, the GINA guidelines. I have to say personally that I followed the GINA beginning, but probably GINA never had such an impulse as Louis-Philippe Boulet was able to prompt in since he was chairing the guidelines. Of course, evidences and science is growing more and more, and probably this is even more difficult nowadays for this job. But I mean, I wish officially to congratulate him about his great job as GINA chair. And today, the topic of his lecture is an overview of the Global Initiative for Asthma 2020 report. I don't want to waste time, and so it's my great pleasure to give the word to our president, Professor Louis-Philippe Boulet.
Well, thank you very much, Walter, for this very kind introduction. It's a privilege for me to initiate this series of webinars for Interasma for 2020-21. And I have the pleasure to provide this overview of the GINA report, the last report. I have to show initially my disclosure of potential conflicts of interest that reflect mostly my involvement in clinical research and education. And of course, I invite you to attend the other webinars that will be given in the next few months. I think we have an amazing group of speakers. And this is an opportunity, a unique opportunity to ask questions to these people and attend, in fact, these most interesting presentations. So I hope you'll be part of the activities of Interasma. I think Interasma has an important role in knowledge translation and update of specialists and primary care physicians, everybody involved into asthma care and related diseases. And I hope you'll enjoy those. Of course, today I will speak about the GINA report and also provide some insight, in fact, about why the recommendations have changed recently. We developed over the last few years an amazing number of documents, videos, slide decks, etc., and even patient documents that you can have on our website on the GINAsma.org. You can also subscribe to the Twitter account of GINA, where my colleague Mark Levy provides regular information about GINA. And I think then you'll be able to follow, in fact, this progress of the recommendation that we update every year, in fact, through the work of the Science Committee. This is an amazing group of specialists from all over the world, both in pediatrics and adult medicine, from all disciplines. And in fact, we have new members, in fact, that have been added since this, the last picture or photo that has been taken at one of the Science Committee in the last few months before the pandemic. So unfortunately, we cannot do that anymore. It's all virtual now, the meetings. But now we have a lot of new members, such as Christopher Breitling from UK, and also we have the past editor of the New England Journal, Jeff Drazen, that is now part of our Science Committee. So I think this group is working very hard every year to provide this updated report and try to guide the care on asthma. And of course, this is consistent with the GINA objective, which is really to initially, well, first, increase visibility of this disease, which is still so common and so unfortunately suboptimal in regard to treatment. We revise the recommendation, provide strategies, try to adapt, and this is a report that is done for the world. So of course, we have to adapt the recommendation to the different environment, health services, and resources. Of course, GINA not only provides recommendation, but it tries to find some evidence for some care gap, for some topics that have not been properly assessed and for which we have difficulty to make recommendations. And in fact, today I'll show you some examples of that. The governance, in fact, algorithm is the following. I have the privilege to be the chair this year, once again, and the GINA Science Committee is chaired by Helen Riddle, who is doing an amazing job. And also that we have the GINA, the Dissemination and Implementation Task Group, chaired this year by Arzu Jorgensioglu. It was by Alvaro Cruz last year. And Rebecca Decker is our CEO, once again, an amazing CEO. In fact, it's just great what she's doing with GINA and support all the activities. And of course, as you can see, there are a lot of people working around GINA. We have now a new group of advocates, which are nominated by GINA as people that have expertise in asthma and can support the dissemination of our reports. And of course, we have new means of communications that I told you about. Of course, GINA, it's always called GINA guideline, but finally, we don't consider that we are a formal guideline. We don't work with the PICO question, with the AGREE tools and all that. But in fact, we base our recommendation on the evidence, on the review of the literature, and on the guidelines that have been produced by the traditional means. For example, recently we had the severe asthma, ATS, ERS asthma, severe asthma guideline. And of course, we look at those guidelines to frame our recommendations. So in fact, it's a document, it's an integrated evidence-based strategy where we try to dissect all the evidence to help the clinician to guide practice and to provide the best care to asthma people according to science. So, of course, it takes care of human behavior. You'll see that today, and also about the various environments. Of course, the burden of asthma is still huge. It's one of the most common chronic diseases. It's just amazing that we still have close to 200,000 asthma deaths per year for a disease, as my old mentor, Freddie Hargrave, was saying it should be a minor nuisance asthma. It should be treated easily for most of the people, but still it's responsible for an amazing morbidity and mortality. What's worse is that it's increasing in prevalence and also in morbidity in many countries. So we have to be careful about that. And in the last 30 years, I've been involved in guidelines everywhere in Canada and internationally, and there is still room for improvement. So we hope that with the various recommendations of GINA, we will face this burden and try to reduce the consequences of this disease. The definition of asthma has not been changed in the last few years, but we insist that it is not one disease, it's many diseases. It's an heterogeneous condition, usually characterized by chronic and airway inflammation. Inflammation is a key word in the definition, but sometimes somebody may have had inflammation that caused airway remodeling, and sometimes we don't find this inflammatory process anymore. But we think that inflammation in most of the asthmatic people has been a trigger and is still responsible for the clinical features. Of course, we have to have respiratory symptoms and the most important physiological marker, which is the variable expiratory airflow limitation that should be proven to really confirm a diagnosis. Of course, this diagnosis, and we have algorithms at GINA that suggest how to do this, we have to document, in fact, the variability of airflow limitation. If we have a patient already on a lot of medication, sometimes it's not easy to do. Maybe sometimes they don't have a variability of airflow limitation, but we have to look in the past if we had evidence for that, or we should do other tests or weaning of medications to see really, is there really asthma? Because some recent studies, some performed in fact in Canada by Sean Aaron and others, show that there is a lot of over-diagnosis of asthma sometimes, but also under-diagnosis. So the prevalence is probably what has been reported, but probably there is a third of asthmatics that don't have asthma, and probably a third of the asthmatics in the community don't have a diagnosis. So I think we have to show something ideally to prove the diagnosis. And this is the algorithm that you can look, in fact, in the GINA report about how to perform this. Of course, in some instances, when the patient comes to the emergency room or shows with a very bad clinical presentation that looks really like a acute asthma, we have to treat, and sometimes we cannot prove, in fact, the diagnosis. And of course, we have to treat right away as if it were severe asthma sometime. But of course, we have later on to confirm the diagnosis, because sometimes we find out that in fact it was mostly vocal cord dysfunction, it was something else, a heart problem. So we should at least try to show something, and if it's not now on first encounter, later on, according to this algorithm. And I will show very briefly the criteria. Of course, it's all the same. It's the variability. We have to have a low FEV1 over FVC ratio to show that there is obstruction. And of course, usually the bronchodilator reversibility should be more than 12% or 200 ml in adults, or 12% of predicted in children. And of course, we can also measure the variability with a peak flow monitoring. Usually, we hope to have at least 10 to 15% change in peak flows, but over time, the larger is the reversibility, the more confident we can think that there is asthma. Of course, we should not forget that sometime in COPD, smoking-induced COPD, they may have some reversibility. So once again, the clinical features are very important to look at. So if it's negative, of course, bronchoprovocation test, methacholine, hyperventilation, exercise, different types of tests can be done to confirm the diagnosis, particularly in mild asthma. When we look at the assessment of asthma, I received, in fact, a question before the talk that has the assessment of asthma been changed from 2019 in 2020? No, it has not changed. In fact, we have the same assessment. We have to look at symptom control over the last month, look at the risk factors, check at the lung function. And of course, in fact, what we insist even more in 2020 is to check the adherence to the treatment, which is such a care gap in asthma, as you very well know. So we have to check the treatment issues, as you can see. And of course, comorbidities can play an important role in the control of the disease, particularly obesity or upper airways conditions. So we really have to check that. So this is an integral part of the assessment of asthma. Of course, the symptom control is key, and this has not changed. Hopefully, we don't want any symptoms, but at least they should not have more than twice a week. When they have a diagnosis of asthma, it should not be more than twice a week of rescue medication need or symptom. They should not have waking nighttime awakening, and of course, they should have a normal life and be able to perform exercise also. However, we have to check for exacerbation risks. In fact, the risk factors such as high short-acting beta-2 agonist use, more than exacerbation in the last, one exacerbation in the last 12 months, a low FEV1, smoking, comorbid conditions, elevated FeNO, all this is, in fact, they are risk factors of exacerbations. And we have to check that because exacerbation is one of the most important features of asthma, can lead sometimes to death or to severe problems. So we have to avoid that, in addition to cause, we think, more airway remodeling and long-term effects if they have many exacerbations. Of course, risk factors for a fixed component overflow limitation should be checked. A certain number of asthmatics don't have full reversibility of expiratory flow. They have developed over time, probably from airway remodeling, a fixed component overflow obstruction. We published a lot on that recently. And even if never smoke, they can develop, in fact, this irreversible component that should be checked. And of course, we have to look at side effects of medications. One of the next most important steps is to distinguish between uncontrolled and severe asthma, because in my severe asthma clinic, and as in many others, and as it's been published, the vast majority of uncontrolled asthmatics don't have severe asthma. They just have problems with the management of the disease. So we have to check the inhaler techniques, we have to check adherence as much as we can. Of course, we have to check if it's really asthma or hyperventilation syndrome or VCD or some other conditions that may make asthma that we see so often. Of course, there are some medication that can worsen asthma. There are comorbidities that can worsen asthma. And of course, if they don't have any of these, then we can consider the need to step up the treatment using the shared decision-making process. We have to discuss with the patient if they agree, what they think about the treatment. Otherwise, adherence may be low. And of course, if it's really a severe asthmatic, they ideally should be seen in specialty, because then we have the new means of non-invasive measurements of airway inflammation, and we have availability of new drugs that we can consider. Of course, this figures, and this figure is very important because it's a control-based asthma management cycle. It starts with the proper assessment, as you can see. We have a decision to make about what kind of medication are needed, and then reassess the response to the treatment. I see patients sometimes that have the same treatment for ages. In fact, it's never been reassessed. And very often, well, the treatment doesn't work. Most of the time, patient has stopped anyway the treatment because it didn't seem to work. There was something wrong with it, not a good treatment. But we really have to carefully reassess response to the treatment by the control criteria, lung function, and if it's available in your center, some measurement of airway inflammation, FeNO, at least blood to see the eosinophils in the blood, or sometime, like in our clinic, we're doing induced sputum analysis. So, but anyway, we have to check if there is a good response and there are no exacerbations and so on. In regard to therapy, to treatment, from 2019 and on, there have been major changes in how we approach treatment. And there are a series of publications that we perform and that have been done to discuss, in fact, why GINA has changed the recommendation. The key one is that all asthmatics should have the availability to use an ICS, an inhaled corticosteroid. No asthmatic should be controlled only with a short-acting beta agonist alone. The SABA alone is from the past. We think it's not. We should not treat an asthmatic patient only with a SABA nowadays, and I will show you why. In fact, when you look at even what we call mild asthma, all the series show that they have major effects of asthma. In fact, when you look at serious adverse effect, a third of those were considered to have mild asthma. Even up to 20% of adults dying from asthma were considered to have mild asthma. And I had the really unfortunate occasion to see that in my own milieu. In fact, many years ago, a young adolescent died from asthma, and his father, who was a physician, told me, I don't understand why he had such a mild asthma, but even mild asthma can die. They can have severe exacerbation sometimes. And I think we have plenty of demonstration of that in the literature. And of course, sometimes the triggers can be variable. Sometimes they may have an infection, a viral infection, or an exposure to something they have been that has caused a severe bronchoconstriction. So I think the reliance on short-acting beta-agonists, in fact, more than 30 years ago, when we did the first Canadian asthma consensus guideline in 1989, we did this consensus because, in fact, people were dying due to over-reliance to beta-2 agonists. And 30 years later, more than 30 years later, we think it's about time to change the way we see mild asthma. And of course, a regular or frequent use of SABA is associated with not only, in fact, the events that I showed you, but in fact, in regard to mechanisms, there is a downregulation of beta-2 receptors. They don't respond anymore to the beta-2 agonists over time. They lose their bronchoprotection. Sometimes there is an increase in hyperresponsiveness. And well, Prof in McMaster and Aldridge also showed that the SABA increase the allergic response. They allow more allergen to penetrate into the airways, and they increase usually the response to allergen and to pollutants, in fact. So the colleagues from McGill University showed many years ago, and this has been confirmed, that if somebody is using more than 3 canisters of SABA a year, this is associated with a higher risk of emergency department visits. And if they take more than once a month, this is associated with a higher risk of asthma death. And this is not in severe asthma only, it's also in mild asthma. And you can have a look at the Sabina study that have just been published this year and last year. They show the same thing. The more SABA you take, even sometimes doesn't seem to be too much SABA, but even sometimes regular use of SABA is associated with an increased prevalence of exacerbation and even death in the Swedish cohort. As shown in this study by Swaru. So this is something that still has been confirmed recently. It's just amazing that we still see that nowadays, this such over-reliance on beta-2 agonists or short-acting beta-2 agonists. So in the past 10 years, GINA tried to look actively at interventions for mild asthma. GINA went to see many pharmaceutical companies to say, can we test this or this? And finally, there were studies that could be done, like the Sigma study that were able to be done and published in 2018 in the New England Journal, that assessed what's happening when you use a combo of SABA, or not SABA, but for example, ICS and Formaterol compared to a regular inhaled corticosteroid, compared to SABA only in mild asthma, in very mild asthma sometimes. So following those studies that I will detail a little bit further on in a minute, the GINA recommendation was that no longer we should recommend SABA only treatment on step 1, and that all adults and adolescents should receive an ICS containing controller treatment. This is, in fact, a strategy to reduce exacerbation and the side effects of asthma, the bad effects of asthma. And it's comparable, in fact, to the other strategy in other disciplines, such as cardiology or rheumatology. In fact, we want to prevent instead to treat. And the many studies have shown in the past that when a patient becomes symptomatic, already there is a lot of inflammation of the air in the airways. There is a loss of control of the disease. And sometimes the SABA is masking the inflammation and is masking the mechanism that can lead to severe asthma. I will not show all the studies, but just a summary of these studies that led, in fact, to the GINA recommendation. So Sigma-1 by O'Byrne and Sigma-2 by Bateman et al. Well, these studies initially, for example, they show that there is a reduction in exacerbation, in severe exacerbation, if you use budesonide formoterol as needed. And it was comparable, in fact, to budesonide maintenance therapy. And it was the same thing, in fact, in the Sigma-2. So we showed that, in fact, on-demand budesonide formoterol led to a significant annualized reduction in exacerbation. But if SABA only were used, then we had a lot of exacerbations. In Sigma-1, there were lower doses of ICS needed for, say, at the same time period. And the percent weeks of well-controlled asthma was slightly lower with budesonide formoterol as needed, which was 34% of the weeks compared to 44% for regular budesonide. So this was a quite small difference between the two. But it showed, in fact, that in this mild population, it could be as effective to reduce severe exacerbations. This is another summary provided in a paper by Paul O'Byrne that showed, in fact, the Sigma-1 and Sigma-2 results in regard to severe exacerbation. And as I told you, ICS formoterol as needed was at least as good as regular ICS. And in this study, you should not forget that adherence to the regular budesonide was probably quite higher than in real life, because it was, in fact, almost close to 80% adherence, which is something we rarely see in real life. But if you look at the SABA as needed, there were really an increased risk of exacerbations. And look at the doses of ICS that were needed. They are quite minimal. And I had a question, in fact, in regard to the cost of this strategy. And of course, there are many studies being done right now to assess the cost of the ICS formoterol as needed. But due to the reduction in the dose needed, in fact, the cost is quite lower. And so the inhaler, they last quite longer. So I think it will be very positive in regard to the equivalence for the cost. Once again, I think we are in an area here where we have to do a shared decision making. If a patient says, well, you know, doc, I'm unable to take this regularly, I don't feel the need, maybe he's a better candidate for ICS formoterol. If he said, well, I want to take it every day and I will stick to that and so on, well, maybe then this patient can certainly take a regular ICS. But once again, this is in the area of personalized medicine, shared decision-making, ideally, and this is, and of course, monitoring of the effects of this strategy, because in one case, it can have to change for the others. So this is very important issues here, even in this so-called mild asthma. And in fact, in the last year, 2 other studies have confirmed that these recommendations could be applied. They are the studies by Beasley and the other one by Hardy. In fact, these studies, in fact, show the same thing, is that the budesonide, well, in this case, it was budesonide because it was supported by AstraZeneca, but it could be another steroid. I'm pretty sure that there is a class effect, although this has to be proven. But you can see that, for example, in the exacerbation rate in the middle panel, that the on-demand combo is as effective as a regular budesonide. And in this, for example, panel C, in fact, you can see that even the on-demand strategy, if you look at severe exacerbation, is even better than regular budesonide, probably, in fact, due to the lower adherence to the treatment over time in a real-life situation. But once again, I think all the evidence nowadays, and this is in thousands of patients, suggests that the GINA recommendation are supported by evidence. And this is the key graph in looking at the treatment. As you can see in adults, and in fact in adolescents more than 12 years old, the step one in patients that have minimal symptoms, less than twice a month, very mild asthmatics. Unfortunately, studies in this group are so difficult to do. I tried personally to do a study in this group in the past on regular use of ICS, and I could not because nobody took the drug. In fact, I had to stop the study. But in fact, we consider by extrapolation, by indirect evidence from mild asthma in step 2, that probably the as-needed low-dose ICS formoterol would be the best treatment, because it will, as soon as they need the drug, they need a bronchodilator, they will at least have an anti-inflammatory agent to help them to control the inflammation. If it's not available, well, a low-dose ICS should be taken whenever SABA is taken, but as you see, as you know very well, patients, sometimes they just rely on their SABA and they don't take another drug, or they don't take an ICS, even if it's offered, if it's suggested. So we have to be careful. And then in step 2, of course, you have the choice between a daily dose ICS with all the precaution that I just told you a few minutes ago, or as needed low-dose ICS formoterol. There are second option, and of course, step 3 is a regular low-dose ICS LABA. Step 4, medium-dose ICS. Step 5, high-dose ICS LABA, and add-on therapy, as you can see here. And of course, for severe asthma, I'll speak about that. We have an increasing number of new drugs that are available, particularly to avoid the bad effects of oral corticosteroids, who are so detrimental. We should not forget, however, that of course, as we don't have any study to look at ICS formoterol in patients that don't have formoterol as a long-acting beta-2 agonist, that in this population, we of course, in this population, the reliever is a SABA. But here again, very important to monitor that the patient is taking its combination therapy with ICS LABA, another type of LABA, because if they still only rely on SABA, they are very, particularly in this group, in these groups, step 3 to 5, they are very high risk of severe asthma events. So we have to be very careful about that. So this is simply to say that I think we now have plenty of evidence that the recommendation are well supported by, these are by the studies that I just showed you, not only in a formal RCT, but also in more real life situation. It's been shown that it's almost even better in real life situation, for example, to use an on-demand ICS formoterol than regular drug, unless you have, as I said, a very compliant patient and you check that. In these studies, we were concerned that there could be more inflammation because sometimes a patient can be left without treatment for a certain period of time. But we were reassured at the fact that FeNO, for example, which is an indirect marker of inflammation, was significantly reduced also in the as-needed ICS formoterol strategy, and there did not seem to be any buildup of inflammation, probably, in fact, because the patient used this drug when he most needed it. So I think this is quite reassuring in this condition. I'm sure that in the next very short while, we'll see plenty of new medication that will associate, in fact, an ICS with formoterol, or maybe in the future some other LABA that have a fast and long duration of action. I think this is very interesting to see in the next few years. I won't speak too much about pediatrics. It's not my field, but this is different in the 6 to 11 years old because in step 1, we don't know really what to do with these kids. In fact, we need more studies. So there is no preferred control. you can see the options that are available here. So in these children, I think a low-dose ICS taken whenever SABA is taken may be good, maybe a preferred option. But as soon as you go to step 2, then it's the daily low-dose ICS corticosteroids. So we need more studies, partly in this population, to do. Maybe the recommendation will change, but for now, this is what we think is the best. So in the 2020 GINA report, there are new graphs on the initial controller treatment, because what I showed you are the long-term treatments. But what do you do when a patient just comes to the lab or to the clinic, and then we have not formally done the whole investigation? Well, as it's mentioned here, if symptoms are less than twice a month, then it's the on-demand strategy that is suggested. If they have symptoms twice a month or more, but less than daily, we suggest that then they can have the option to use the ICS regularly or the as-needed low-dose ICS Formaterol as first choice. If they have symptoms most of the days, or they have disturbance of sleep due to asthma, I think then we should start with a higher dose of ICS. And if they are controlled, we can try to step down. We always have to adapt, to step up and step down according to the control. But if they have symptoms most days, or waking up with asthma once a week or more, then the medium dose, or even the high dose in some cases, if it's more severe, should be taken. And of course, in some patients with a very bad asthma, particularly if they have quite a marked reduction in lung function, of course, we still sometimes need to use oral corticosteroid, prednisone or prednisolone for a few days to get this control. But of course, at the same time, we have to add a combination therapy with an ICS LABA, ideally at a good dose, see the patient regularly, more quickly, and then try to see, as soon as control is achieved, can we lower the dose of ICS? What is the minimal treatment needed to have the optimal control? And this sentence, in fact, my mentor told me that when I was a young fellow 40 years ago in McMaster. He said, the goal of the asthma treatment is to get the best control with the minimum treatment needed. And of course, be able to adapt the treatment to the situation. So I think it's still very true nowadays. So this is the same thing that I showed you. And of course, there are some maximum dose that are in fact recommended for these drugs. Of course, for budesonide, Formaterol, usually we don't need to go higher than 8 puffs a day, but there are some toxicity studies that suggest that we may go slightly higher. For the beclomethasone Formaterol, we still have some studies that showed at least 6 inhalation of beclomethasone Formaterol 100 can be given, but it's probably higher than that. It's just that we don't have all the data to suggest what is the maximum dose tolerable. And this is the same for the other ICS. So of course you have a table, sorry, you have a table in the GINA report about the equivalence. Well, I should say, I still make the mistake. This is not a table of equivalence. I'm so sorry. I think we keep saying that, but in fact, they are suggested doses for low, medium, and high, because once again, apart from very recent few studies on proper equivalence studies looking at the efficacy of a drug compared to the systemic absorption, most of the studies are not really of a very high quality to compare the different drugs one from the other. So they are, in fact, suggested, well, once again, we can say equivalent, but suggested a low, medium, or high dose of ICS. So I think it has to be taken with a grain of salt, waiting for more studies. Just a warning, in fact, we had to add to the report, sorry, the warning from the FDA about serious side effects for asthma due to Montelukast. I think this is something that can happen, and we should be aware of that. Of course, oral corticosteroid, systemic corticosteroid should be absolutely avoided. They have an amazing number of side effects that they can cause many conditions, contribute to many conditions, diabetes, cataracts, everything, osteoporosis, and we should avoid that as much as possible. Of course, this is in increasing the doses of ICS sometime, but at some point in severe asthma, with proper assessment of the control and severity, then we should try to do something else and give other drugs that we now have available. And these are summarized in the GINA Difficult to Treat and Severe Asthma Pocket Book. I think this is an amazing book. I think we took quite a few years to develop that with consultants and many people that are specialized in communications. And in fact, this book is updated regularly. And the content is included in the full GINA 2020 report. It includes all the drugs that are now available to treat severe asthma or could be used in severe asthma. Of course, the dupilumab is not on the market yet, but in many countries, dupilumab is on the market now, targeting the IL-4 receptor alpha. But once again, I think if you look at the different algorithms and tables, then you can see what we recommend in regard to the targeted patient that can benefit from a drug to the other when they have severe asthma, and in whom all the previous workup have been done to really prove that it is severe asthma. So doing that with these biologics, of course, they are expensive, but they are an option now to avoid taking systemic corticosteroids or wean these corticosteroids, these systemic corticosteroids, to then prevent the side effects and the bad effects on different conditions. And of course, there is a resurgence of studies recently on the damage that the systemic corticosteroids are doing. So this is something to consider. And of course, for these patients, it's very important to assess the response to see if they respond to this biologic that is chosen. Otherwise, we can decide to change for another type of biologic, considering the biomarkers that we have been measuring. We have to speak about COVID. We live in a new world now. This pandemic there is a second wave, even in Canada now. And of course, we have to minimize the risk for healthcare givers. So we try to avoid spirometry. Of course, we should avoid spirometry in patients with confirmed or suspected COVID-19. And even in the other patients, we have to be careful and do some measure to prevent the transmission of particles, of viral particles. We privilege the use, for example, of inhaler with or without spacer chamber, and avoid as much as possible nebulization, which is producing more dissemination of particles. Of course, you have to follow the guidelines, local guidelines and local public health recommendations. I should mention, however, that a recent study by MAIS in Brussels showed that for asthma, there doesn't seem to be an increased risk of severe COVID unless pulmonary function is impaired, if asthma is really uncontrolled, if they have frequent exacerbation, or if they are taking systemic corticosteroids. If they don't have that, they probably have no increased risk of COVID-19. And the severity of COVID should not be more severe than in a normal non-asthmatic subject. And in fact, in the cohorts of COVID, asthma is underrepresented. And in fact, there are studies right now that look at the potential beneficial effects of the inhaled corticosteroids on the prevention of severe COVID. We know that dexamethasone in the very severe cases can work, but in other patients without such a severe COVID, maybe ICS can protect also. So this is something we have to follow, and the results of those studies will be extremely interesting to look at. But what's very important in regard to COVID is that the asthmatic patient should keep taking their medication. As I showed you, uncontrolled asthma is a high risk of getting bad COVID. So they should keep the same medication. We have the proof. We have, in fact, all the evidence right now that these drugs are not detrimental and may even help to prevent severe COVID. They should, however, be able to apply an action plan if they have an exacerbation. You know, we're starting the influenza season, and of course, they may have exacerbation due to other conditions, and not only the COVID. But even if it's COVID, in fact, they have to act very quickly to control asthma with an action plan, ideally, and again, avoid nebulizer. So these recommendations may change over time, so we have to check the various publications from WHO and local health, public health organization to check, in fact, in regard to these suggestions for asthma and other diseases. Just a word about ACO, asthma COPD overlap. There has been such a debate over this condition. I mean, we have to realize that it's been for ages that we know that some patients with asthma seem to have a COPD component from smoking, for example, or COPD patients have a component of asthma, as shown by tremendous eosinophilic inflammation, variability, overflow, limitation, and so on. So asthma COPD overlap is not a single disease, but it's a description of variable overlap in both asthma and COPD. And of course, there are many types of overlap. Some have a lot of asthma, few COPD features. Some have huge COPD feature, a few asthma features. Some have a mix of different things. So we have to, I think it's still very important to speak about the overlap, because there are some important points to remember is that, sorry, if you think there is an asthma component, never treat with bronchodilator alone, as we do sometimes in COPD. If there is a COPD component, so don't start with an ICS alone. We should start with a long-acting bronchodilator, and without ICS if we think there is absolutely no asthma. So there are considerations in regard to the treatment according to our assessment of the presence of asthma and or COPD features. So this has been detailed, in fact, in Chapter 5 of the 2020 GINA report. So I refer you to this chapter if you're interested. We have many tables and figures like this one to see, okay, how to treat like asthma, how to treat as COPD, how likely is it to be asthma, how likely is it to be only COPD. So I invite you to look at those. So in conclusion, because the time passed so fast, over the last 25 years, GINA has produced many reports, guides, and recommendations taking into account treatable treats. And in fact, we have been accused sometimes not to consider treatable treats. This is completely wrong, because for the last decade at least, and even more, we always suggested to have a personalized approach according to the various subject characteristics, including clinical, physiological, inflammatory features. We still have, of course, progress to be done in this regard with better biomarkers, better other means of assessment of phenotypes or endotypes of asthma. But this is there already, particularly for severe asthma, as you could have seen. So the report is revised annually. It's an amazing amount of work. In fact, we've spent, I don't know how many hours in front of our computers at the science committee recently to still review all the literature on asthma and see what would be best in regard to recommendation changes or not. And of course, we have a wonderful dissemination and implementation committee producing many tools, many means to help you to apply, in fact, these recommendations into care. And I thank all the advocates, the GINA advocates that have accepted to contribute to that. So I refer you to the website, ginasma.org, and thank you for attending this presentation. I'll be happy to answer some questions. I think I have some questions now. There was a question about changes from 2019 to 2020 report. In fact, it's about the same. We added some tables, as I showed, and figures about the initial treatment of asthma, and we insisted on adherence to treatment also. There was another question on the cost of the on-demand strategy with combo. Well, as I said, in fact, we have studies on that right now that will be performed. But as we use less drug than in a regular ICS treatment for mild asthma, for example, we believe that it will be equivalent, or we can maybe even save some money in regard to the treatment with as needed ICS Formaterol. So we'll see these studies. There was a question on the increase in SABA. Why do we say that SABA should never be used alone? Well, I think we have many evidence to suggest that right now. And there was a suggestion that maybe we can monitor the use of SABA by electronic means, also report to the pharmacist. Well, this is very good, but of course, as you see in normal life, in real life situation, this is rarely applied or available. So unless we have an inhaler of beta-2 agonist that dictates some recommendation to the patient and suggests to take an inhaled corticosteroid or something else, before that time, I think we have to consider other options, such as the on-demand ICS Formaterol, if we want particularly to prevent severe exacerbations. So, but they are very nice and good comments, of course. I'm sure that in the next few years, we will see many new tools for the patient to use the medication appropriately, depending of the circumstances. There was another question on why exercise training has not been included into the GINA. Well, there have been consideration about exercise on page 89 of GINA. But of course, in the etiology of asthma, GINA has not insisted on the fact that high-level competition for many years can lead to asthma. This is now a fact, I think. But we mentioned that the prevalence of asthma is higher in athletes, and of course, the recommendation on treatment of athletes have been produced. Probably in the near future, we can add in the appendix, because we should. If you want more information on all that, you should also look at the appendix, which includes, in fact, many information on mechanisms and physiopathology. We probably will expand, in fact, on the links between high-level competitive sports and asthma. So these were the first question that I got. Let me see. There is another question by Dr. Dermott. There is a huge overlap in symptoms between those with mild asthma and those who do not have asthma. It makes sense to clarify the diagnosis of asthma rapidly, rather than in 1 to 3 months time frame, rather than commencing them on a regime, which is unnecessary if asthma is not present and suboptimal in terms of annual loss of lung function to regular treatment if asthma is present. Well, I certainly agree with that. I mean, as soon as we can, in fact, confirm the diagnosis, this would be ideal. I'm sure that in many instances, we can confirm the diagnosis very quickly, particularly if you have availability of bronchoprovocation test in mild asthma. Of course, the pandemic complicates the situation a little bit more. But nowadays, if I don't have availability of methacholine tests or other tests, I give a peak flow meter to the patient and I ask him to regularly record the symptoms and the change in the expiratory flows. And then I can have some idea about reversibility of airflow obstruction. So I think we should try to confirm the diagnosis as soon as possible, and I agree with that. And one of the problems, if we start an ICS right away without a confirmation, sometimes the ICS will normalize airway hyperresponsiveness, and then we won't have an evidence of asthma. We'll have to stop the ICS once again and then redo the test. So of course, the more quickly we can check, the best it is, certainly. Does bronchial thermoplasty has any place in the GINA guide? Well, We speak about thermoplasty, yes. It's not a preferred treatment because of the potential side effects of the treatment. Of course, when this is applied, which is quite a invasive treatment, unless it's simplified in the future, there are 3 bronchoscopies and the treatment is a bit complicated and sometimes costly in some countries. And of course, following the treatment, there are some exacerbations initially. So this is an option in patients where we cannot do anything else. But for now, we think it's better to consider some other option before considering thermoplasty. But this is still an option that is possible. So what would be the maximum dose of Formaterol ICS and the frequency of use on demand to prevent exacerbation? Well, as we saw in the Sigma studies, this is quite variable. Usually people don't take that much ICS. There are some periods where they can go up to 8 to 10 puff. If we look at the toxicity study, we can go easily up to 10 to 12 inhalations of Formaterol and ICS, the current doses, with 6 micrograms of Formaterol per puff. But I think, once again, what's important, even in my patient that have, for example, an action plan based on increasing the ICS Formaterol dose if they have an exacerbation, if there is a trend toward a marked increase in the need for this medication, they should consult, because sometimes they are too severe, even if they are mild asthma to start with. They may need, in fact, something else like oral or systemic corticosteroid. But usually, in fact, if you go up to 8 to 10 puff a day, I usually suggest to increase to 8 inhalations a day, 4 puffs in morning and evening. And this is sufficient in most cases. And in the studies, in fact, there were no cases of abuse of this drug. So it was quite reassuring. It prevented, in most instances, the exacerbations, but we have occasional case where it's not sufficient, of course. Let me see the other question. What is the best way to protect a person who has asthma against COVID? Well, once again, I think the usual preventative measure, washing the hands, having a mask, wearing a mask, avoiding crowds, avoiding meeting many people, the usual recommendation from the health authorities should be applied. As I said, it seems that the asthma drugs may have a protective effect, but we are not sure of that. And what's the most important message here is that don't stop your medication. Take your medication according to the prescription that has been given to you. If your asthma worsens, apply your action plan. Don't let your asthma get under not controlled, because then you'll be at more risk. If you catch the virus, then you'll be into trouble. So a good control of asthma is absolutely mandatory in this period of COVID. I have another question. Does triple therapy in a single inhaler has any place in the GINA guideline? Well, in fact, many studies, in fact, will be published in the next few weeks, in fact, about triple therapy and asthma. So the GINA Science Committee has considered that for now, we didn't have enough study to make a formal statement. You know, we try to have at least 2 RCTs in approval in some countries of the drug. Right? We try to get sufficient data to have solid recommendation. So probably in the next GINA report, you'll have recommendation about triple therapy. Of course, this seems to be an interesting mode of treatment for severe asthmatics, but you'll have to wait for the next report. Let's see, do we have other questions? Thank you again for these questions. I think they are very relevant. I think this is about that for now. Well, first I would like to thank you for attending this presentation. I hope it was useful to you. And if you have any other questions, you can send me an email. I'll be pleased to answer those. So I'll just wait a few seconds if there are no more questions. No, seems to be all. So thank you so much. And please hope to see you for the next webinar next month. It will be on COVID and asthma, in fact, COVID and respiratory diseases. So not miss the next webinar. Thank you so much for being there. Bye-bye.